He thought he'd had every medical scan possible, but then a routine checkup revealed a surprise. A faint sound no one had ever detected before. The hidden heart defect it revealed on today's All Things Heart. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. 40-year-old Per Christensen had already faced more than his fair share of health challenges. And then he learned there was yet another. He was living with a congenital heart defect, and it went undiagnosed until he was an adult.
It's crazy that it's only been 5 weeks since heart surgery, and I was not expecting to feel this well.
40-year-old Per Christensen thought he already had his fair share of health problems.
I've got a liver disease called primary biliary cholangitis. I've got ulcerative colitis. I've got a history of kidney stones.
But in the fall of 2023, he was hit with another diagnosis. While he felt he'd already had every scan and test under the sun, he kept his appointment for a yearly physical just to tick that box. It was at that appointment his nurse practitioner, Mary Kaiser, surprised him.
Took a listen to my heart and said, "Hey, has anybody ever told you you have a heart murmur?" And it's like, nope, not a single person's said that before.
She said it was a very faint murmur, but unmistakable. Further scans revealed the cause, and this time it wasn't something Per had, rather something he didn't have.
Most aortic valves have 3 leaflets, mine only had 2.
His aortic valve was missing a leaflet. The news was beyond disappointing.
Okay, great, another thing, like let's just add on being like, hey, when is the other shoe gonna drop? Like it feels like every time I'm coming in, there's another thing to add to the list.
In September of 2025, new scans showed Per's heart valve function was getting worse. He was next sent to cardiothoracic surgeon, Dr. Todd Crawford.
I heard the name and saw, let me go to Google and see who this is. And sure enough, All Things Heart came up. And I was immediately like, well, let me start watching this. And then I was sort of like, oh, we've got a surgeon at the hospital who is also a patient. And I was like, oh, this is great.
Dr. Crawford, a frequent expert featured on All Things Heart, had once also joined the show to share his personal journey as a patient, undergoing open heart surgery years ago.
I mean, it was great. I mean, it's not the exact same thing, but he can also say, like, look, like, I've got the scar too.
Dr. Crawford had a 3-step plan to fix Per's heart, a surgery called a Ross procedure. Step 1, remove Per's aortic valve. Step 2, replace it with Per's pulmonary valve. Step 3, put a donor valve in place of Per's pulmonary valve.
Pretty much after that first meeting, I was like, let's go.
Today, he is so grateful to Dr. Crawford and for his nurse practitioner, Mary Kaiser, who detected the faintest of heart murmurs.
She's got good ears.
Thank goodness for good ears and a very, very smart nurse practitioner. Joining us now is Per Christensen, along with his cardiothoracic surgeon, Dr. Todd Crawford. And of course, we have the nurse practitioner who diagnosed the murmur, Mary Kaiser. Per, your mom wanted to give a gift to Dr. Crawford, your surgeon.
Right, so I will let you open that.
Now, is this handmade?
Yeah, so my mom knits a lot, and so when I the day of my surgery, she started knitting me a blanket, which she finished in 7 weeks, and then she started on socks that have heart patterns on the back.
That's so sweet.
That's amazing.
Afterwards, so she wanted to send that as a token of gratitude to you. So
thank you so much.
So
That's very special.
the main thing she wants to say is make sure you read the washing instructions.
Oh man. I love how the bond that you form with the patients and their families. I'll take the socks.
Oh, thank
we'll
you.
keep them in safekeeping. Oh, these are very soft.
Yeah.
Let's learn how she did that.
Does good work. So.
She sure does. Per, you're 2 months out?
So
now,
12 weeks.
12 weeks.
Of Tuesday.
So you're past the 3-month recovery.
So I just went back to work yesterday. I was at cardio rehab yesterday and started jogging for the first time, which was crazy, but felt really good. So legs are okay this morning. So I think doing all the bicycle stuff and steppers and things like that sort of set me up for success there. So, yeah.
And Mary, you're the one who detected the murmur. First of all, what does a murmur sound like compared to a typical heartbeat?
Yeah, and thanks for inviting me to share the story today. It's a great story. A normal heartbeat is kind of what we consider the normal lub-dub. It is regular, it's consistent. But in Pierre's case, we hear like a little swoosh dub, just a very faint, something you can't miss, but something that I noticed that was a little bit different.
And what prompted you then to refer him to a cardiologist?
Yeah.
Was it just the murmur that you picked up?
Yeah, so whenever I hear something that I'm like, this is a little different, I want to get more information. So with Pierre, we ended up getting an echo, which is kind of like an ultrasound, which we do for pregnancy. We look at babies. For him, we actually looked at the heart, and we looked at how the structure moves, how the valves move. And like you said, you had 2 instead of 3. And so when I saw that, I knew we needed to refer him to the right team. And I talked to my collaborating physician. He said, yes, let's go to cardiology.
Right. And then what we're talking about is the bicuspid aortic valve. So Dr. Crawford, for people who don't have a medical background, can you describe what a bicuspid aortic valve looks like compared to what is a typical one?
Yeah, so it's a congenital condition, and it's quite prevalent in the population, 1% to 2% of the population, and I think we're much more aware of it now. We're better at diagnosing it. But the normal aortic valve formed in utero has 3 leaflets. And so the flow across that is laminar or not turbulent. But when it's a bicuspid valve, the opening of the valve is irregular, and so there's trauma to the leaflets over a lifetime. And the way we heal trauma is we tend to have tissue thicken or calcify, and then it inhibits the opening of the valve leaflets, and it leads to something called stenosis. And patients like Per get symptomatic from having to work against that fixed obstruction in their valve over several years. And that's when he came to us, he was already experiencing those symptoms.
How common is it for someone to be born with a bicuspid aortic valve and have it go undetected till they're 40?
The story is really cool for many reasons, but I was just like you in the sense that I played sports all through childhood, 18 years, and never was told I had a murmur. I was working for a nurse practitioner my first summer after college, and I was having chest pain, and I went to see the nurse practitioner, and she said, you have a diastolic murmur. A little different than yours, but still abnormal, and that's how I found out about my bicuspid valve.
So a nurse practitioner as well?
Yes.
Mary, if you hadn't detected the murmur, how dangerous would that have been for Per moving forward?
I mean, I might defer that one to you a little bit.
That's
but
incredible.
Yeah, it is.
Yeah.
How dangerous would it have been if Mary hadn't been there and detected the murmur?
I mean, in extreme cases of aortic stenosis, it can be life-threatening. But typically what we see is just progressive exercise intolerance, worsening shortness of breath, fatigue, many of the things that he was experiencing.
Have you always had good ears? How often do you pick up murmurs, faint murmurs?
I mean, the good news, like during physical time, it allows us time, and I always say us nurse practitioners have more time than the physicians, and so we have a little extra time to listen to the heart and lungs during physical times, and sometimes we pick things up. So not honestly very uncommon.
Wow, I do love nurse practitioners. I love doctors. I love how nurse practitioners, though, do get to spend a little bit more time in the room because doctors are getting pulled in a lot of directions. Would you say that's the case? Your nurse practitioners tend to have that ability. Per, you have several chronic illnesses.
Yeah.
This diagnosis hit different.
It did, yeah. I mean, I think from the standpoint of having ulcerative colitis, having the liver disease, it's more, I don't know, those are not the engine that's driving everything else. And so finding out like, hey, you've got these things going on, and then by the way, you also have a heart condition, and that's potentially going to complicate some other stuff. And what's been interesting in the 12 weeks in surgery, I was having a discussion with a fellow patient at rehab the other day, and they had asked me, how are you feeling? Like, and I was like, better, right? And it's amazing to look back at that pre-surgery feelings and realize how much I was compensating for things that, like, my heart was just working too hard and I didn't recognize it or wanted to ignore it or whatever. And so to be on the other side of that helps clear up the mind and then kind of say, okay, the ulcerative colitis is managed with medication, the liver disease is managed with medication, the heart's fixed, so like, we're good.
You're good.
Right? So it makes a difference, to say the least.
It's interesting. You don't know what you don't know.
Right.
So whatever you're feeling your whole life, you just assume is how you're supposed to feel. Looking back, what are the things you look back on and say, oh my gosh, well, that was my heart, but you just didn't realize it?
Again, talking to a patient the other day at rehab and having I finish exercise at rehab and I sit down and I will be sweating, but I'll stop relatively quickly. And in the past, it would be like, oh, I'm going to walk someplace. I get back home and then I'm still sweating 20 minutes later,
Okay.
right? And so not having that, it's like at the time, maybe you make excuses in your head or whatever, just wonder like I have an overactive.
I just sweat a lot.
Right,
Yeah.
and instead it's like, oh no, like your heart was working a little
wow.
harder. So
Dr. Crawford gave you 3 options. What made the Ross procedure feel like it was, well, I'll ask Dr. Crawford this question first. What made you think the Ross procedure was a good fit for Per?
Before I answer that, I have to give a little background for why this is the best fit. I mean, when you are diagnosed with something, you tend to kind of consume yourself with the information surrounding it. So, just like Per, it was the same for me when I was younger, and that was my why for why I do what I do now. And what I learned is that having your aortic valve replaced is a really serious condition. It seems like it's an easy operation, patients tolerate it well, but it changes your lifespan. In 2022, there was a paper put out that demonstrated that if you had your aortic valve replaced at any age, your risk of death in the next 15 years was 10%. If you were a regular individual without aortic valve replacement, it was only 5%, so the mortality was double. And the only thing that could recreate a normal lifespan in those individuals was the Ross procedure, because it's a living, breathing valve in the aortic valve position. You don't need blood thinner, and there's not a finite timeline like a bioprosthetic valve. You could potentially live the rest of your life with that valve. And so, when it came to Per, we knew that valve repair was not an option. His valve leaflets were thickened and calcified and not opening normally. Valve replacement was an option, but he had some serious medical conditions. For instance, he has ulcerative colitis, which puts him at risk for bleeding from his intestines, and he also has primary sclerosing cholangitis, which is associated with ulcerative colitis, and that puts him at risk for liver failure or liver injury over time. And so both of those issues make warfarin really dangerous drug in him.
And warfarin is a blood thinner.
And it is an obligation if you pursue a mechanical aortic valve.
Okay.
A bioprosthetic valve in someone his age, we could reasonably expect to last 5 to 8 to 10 years. So it's not a durable solution before he would need potentially open heart surgery again.
So you knew the Ross procedure.
So I felt the
Was
Ross
the best.
procedure was the best thing for him, and we talked a lot about it, and that's what we settled on.
I do have a question for Mary. As a nurse practitioner, how common is it that you have a patient like Per who has a slew of other health complications, which, gosh, you've been through a lot. So overwhelming, and you've handled it like a champion.
Appreciate that.
How common is it that you are seeing a patient who has these other things and also will have a heart problem?
Yeah.
And how are these related is what I'm getting at.
Sure. So in internal medicine, we see very complex patients. And so we have patients that have chronic issues and they have other things going on. So you have to manage all their chronic issues and then the new things that come on. And so if the liver is acting up or the kidney problems, can you be at high risk for heart things like coronary artery disease, or yes, it makes you at higher risk, but usually we see a lot of co things together.
Okay, and so once you talk to Dr. Crawford and you decide on the Ross procedure, how quickly were you able to make that choice? How soon after meeting Dr. Crawford?
I mean, pretty much immediately. I think that was the thing for me. We discussed during the initial consultation, I spoke to somebody initially who was kind of like, well, we've got a mechanical valve, we've got a bioprosthetic valve, here are the pros and cons of both of those. And then when Dr. Crawford came in, he also said, hey, there's a Ross procedure. Have you heard of this? Do you know about it? And I kind of figured I wasn't a candidate for it. So to have him say, no, you actually are a good candidate based on the structure of your heart, that was helpful. And then when he explained it and basically said, your life expectancy falls in line with the general pop. If we do this and you don't have to be on blood thinners, like I think I told you right off the bat, my biggest concern with a mechanical valve was being on warfarin and what that would mean in relation to ulcerative colitis and things like that, and how those might all complicate each other. So to have this as an option, really, I mean, it was a very easy decision, ultimately. So.
And you talked about how you had this trust in Dr. Crawford because you looked him up on YouTube.
It was helpful to see that he had also been a patient and
Yeah.
can speak from his own experience. I mean, that's an amazing opportunity to be able to work with somebody like that who can, I think during that initial consultation as well, it was like, hey, physically you're probably going to be fine. You're going to bounce back. You're 40. Like, it should be pretty good. It's the mental health that's going to be a little tougher because of, make sure you've got a good support system, and thankfully
Sure.
I do. So it's made a difference, to say the least. So it's nice to have somebody who can speak to that, speak from an expertise, saying, hey, these are all like the really mind-blowing things we're going to be able to do with your body, right? But also, I've had some of that work done myself, and I can speak to you on what it's like as a patient.
Which is so comforting.
Exactly.
So comforting.
Exactly.
We have some images, Dr. Crawford, I'd love to have pull up for our audience. What are we looking at here?
Yeah, so this is what a bicuspid aortic valve that has failed looks like. So you see the top leaflet, which is two leaflets that are actually fused together, which likely happened in utero. And then the bottom leaflet, which is what we call the reference leaflet, or the single leaflet that's also heavily calcified. So the first thing we do is we cut those leaflets out, but before we can sew a new valve in, even a pulmonary autograft or the pulmonic valve, we have to debride the rest of the calcium away from the annulus or the frame of the valve. So that's what all the other tissue is there.
So that's all like calcified things,
Yeah.
debris?
Yes.
And then the other two are his old leaflets. I just need to ask about size. Like holding up this pen, how big do you think on this pen his leaflets were?
Yeah, most
Like-
so I look at the replacement options for valves. So it's from 19 millimeters all the way up to 29 millimeters if you use a
How big were
prosthetic valve.
his? Like those things we just saw?
His were probably somewhere in the middle, 23 to 25 millimeters.
Like
this is the
that?
annular diameter.
So like I want to show our audience like that much?
Yeah, about like that.
About like 2
Yeah.
inches? Wild. What's it like seeing those pictures?
I mean,
Have you seen those before?
Yeah, I saw those when we met post-surgery. My mom had seen those. And so I hadn't seen them yet, and she's like, "Yeah, I saw your valve. It was gross." And I was like, "Yeah, it's weird to see the inside of yourself." That you
And
didn't
why
know I
did you
see.
move the pulmonary valve instead of using a donor aortic valve?
Yeah, so like we talked about, the two options: the bioprosthetic valve, which has a very finite lifespan, especially in a younger patient, or a mechanical valve. Both have inherent risks over a lifetime. Whereas the Ross is essentially using a living, breathing autologous valve that we just transpose into the aortic valve position, and it functions much in the same way. The structure of the valve is very similar, and as long as we get the geometry and the orientation of the valve appropriate for you, then that valve could potentially last the rest of your life in the aortic position.
Mary, we talked about how Per obviously wanted to avoid blood thinners. But one thing you said that I wanted to ask Mary about is you talked about the need for the emotional and mental support. What did that conversation look like when you had to give Per this news that, oh, we've got another thing we need to check out in you?
Right. And I think the important thing is whenever I order a test that we know and set expectations what we're looking for. So when the echo came back, I'm like, okay, there's something a little different, that it wasn't totally out of the blue. One of my colleagues always said, be honest, patients don't need to panic, they just need to know that you have a plan. And so our plan was just being upfront and saying, you were born this way, we're glad we caught it, we'll get you to the right team. And just know that we're part of your support team. You're never going through this alone, even though you have your cardiology team and everybody, us as your primary care, we're always here as part of, to help you out as well.
Yeah.
And you talked about the collaboration you got with your health collaborators, and you were able to get Per to Dr. Crawford. We already have some questions and some comments coming in from the audience. So if you have a question or a comment that you'd like us to read out loud on the program, you can send it to us right now on YouTube, Facebook, or the All Things Heart email, and you'll find the links right here on your screen. Do you have a comment right off the bat? Marcia says, Per is such a cool name.
I mean, can thank my parents for that. So
What is it, French,
Scandinavian.
German? Scandinavian.
Yeah, so there was, there's already a Peter in my family, and so I got what is essentially the Scandinavian equivalent of
Per.
it. Yeah, so a little tough growing up, but my dad, at one point in time, got out a Danish phone book, like the Copenhagen phone book, and said, look, you're not the only one. Here's like a full page of Per Christensen. So
It's like the name John in
Right.
Scandinavia,
Right.
right? Or Peter, obviously. Dr. Crawford, Per went home in just 5 days. How typical is that after a surgery like Per's?
You know, it's not atypical in a young patient that has a normal heart. You know, that makes a huge difference going into it. We knew he would tolerate the surgery well because both of his ventricles work well, and he's a motivated individual and, you know, committed to his rehabilitation. So, you know, he was up in a chair and walking the day after surgery, not on any medication to support his heart. That's usually
Wow.
a good indicator he's going to progress rapidly.
Who are you with in that picture?
Oh, that's my mom.
That's Mom?
That's
The knitter?
Yeah, that's my mom, the knitter.
Uh-huh. And what's the kitty cat's name?
So his name was Magnus.
Oh,
Yeah.
Magnus.
And then at a community farm there, and then that's from my dad's celebration of life. That's my whole family, the majority his side. And
You have a
then,
great family.
that's my kitten Elin, and then her sister Lucy and her a little bit older. So
We also
yeah.
have a video of you undergoing some cardiac rehab
Oh, okay,
that
sure.
we want to play.
Probably doing it a little bit more
On the
because,
rowing machine.
Yeah,
Okay.
that was the day that weight restrictions got lifted. So and
How
then,
soon after your surgery was that?
That was 6 weeks.
Okay.
So I was looking forward to being able to do some upper arm stuff, to say the least, because just doing bike and doing a stepper without using the arms was getting a little redundant.
What, you're looking good.
Oh,
And doesn't look like
appreciate
you're
it.
sweating very much in that video.
Was doing all right.
Yeah.
Taking it pretty easy there since I hadn't rowed in years. So.
What's the hardest part of rehab for you?
I mean, it is, you know, you recognize still, like, there are times where I know I don't have my stamina quite back yet, right? And so I think there is I feel really good physically, I should be able to do the things. And then you just kind of have these reminders of like, hey, by the way, and I've had conversations with friends being like, give yourself some grace. 12 weeks ago, you were on a heart-lung machine with your chest open, right? So it's expected that maybe you know, get a little winded here and there. So I mean, it's giving yourself grace and just kind of understanding that, like, hey, if all you've accomplished after 12 weeks is I've recovered from heart surgery and I'm in a good place, that's enough.
And you're in a great place. Are you back to gardening, doing your community gardening?
So I need to go back. I was on babysitting duty for a while because I wasn't gonna, you know, be digging in the ground. When
What's
I was on leave.
babysitting duty look like?
So we've got a little farm baby there. Some friends of mine. So I was holding on, sort of letting other people work while I just sat there with the kid.
Oh, well, you held the baby?
Yeah.
That's a great job.
Yeah.
I
No,
love
I mean
that.
it's a nice way to spend a Sunday afternoon.
Wonderful.
So.
Mary, I got to ask you, because this all started with a routine physical, and Per, you had admitted you were like, ugh, I've had every test under the sun. Why do I need a routine physical?
Well, I think I had gotten through all of the check marks for that year for all of the extracurricular activities that I have here at the hospital. And so I was like, oh, I'll just go in and see Mary. This is going to be easy. Like,
Right.
no problems. And then, you know.
She caught it.
Right. Here we are 2 years later.
So Mary, what would be your message to other patients who think, hey, I've already had a battery of tests. I don't need this routine physical?
Yeah, and I think it brings it home because you had everything done already, but for my standpoint, you're relatively still healthy for that time, and so doing your routine physical, it takes time, and I get it. I got 3 kiddos at home. Life gets busy. We can push back appointments, but it's so important to make it a priority because we can take time to listen to your heart and lungs, order preventative care, and sometimes we catch things.
Right.
We can catch things early.
Yeah.
So, yeah.
No. I mean, and that's what's nice. I mean, ultimately, I can look back at the last 2 years, and it's the anticipation of all of this. And so to be on the other side of it is really, I mean, makes all the difference from not having this kind of hang over your head as you watch, you know, obviously we're doing the things we need to do, right, over the last 2 years and monitoring and making sure. But to now be here and to be on that other side of it is really, I mean, it's really wonderful. So.
Let's get to some of the questions from our viewers right now. We have a question from Jean. Jean wants to know, what's the risk of living with a bicuspid aortic valve undetected? Dr. Crawford.
Yeah, I mean, I think the primary risk is that about 40% of those patients will also have aortic dilation. And that is the more life-threatening. If you have associated aortopathy or enlargement of your aorta, then you have a risk of dissection or rupture, which is life-threatening. Living with a valve that's abnormal, I mean, they almost always are detected in some way, either with routine auscultation of the chest, or you get an echo for some other reason and they find it. So, you know, living with the valve itself usually gets symptoms before you progress to a life-threatening predicament.
Denise has a question for Per. Denise wants to know more about how your system, your body has changed. She talked about how, since you mentioned you used to sweat a lot and now you don't sweat as much. What else have you noticed?
I mean, there are things, you know, my mom and I had conversations in recovery where I would have what I never considered shortness of breath, and I assume might be allergies or something like that, but I would have these moments of, I want to take a really deep breath and I can't quite get it. And, you know, so I would be having a conversation with somebody and then be like, almost like this trying to gasp for air. It never occurred to me that, like, oh, this might be my heart. And since then, that just doesn't exist anymore.
I remember you saying your mom had noticed that, pointed that out
exactly.
to you.
Yeah, it was something that we talked about post-surgery, where it was just that time spent together while I was in that initial recovery phase when she was staying with me, that she just said, like, you know, you're not doing that anymore. Like, you haven't done it since surgery.
Wow.
And so there's things like that, again, where you kind of look back and it's like, oh, okay. Like, and I mean, just even from the standpoint of, it feels like the other conditions, I mean, test results so far have been good, but even like ulcerative colitis symptoms have been non-existent. Things like heartburn I haven't had that since the surgery, which has been great. So I'm really fortunate, really appreciative to say the least. So.
Question for Mary. Tim wants to know, as a rule, how often should people be getting physicals?
Yeah, so normal, healthy adults, we usually do an annual physical. And I tell patients, I want to see you when you're healthy. So if something changes or something, if you're sick, I kind of know what your baseline is. Sometimes we have sicker patients that have more chronic conditions, and we do want to see them a little bit more frequently, but it's always important to talk to your primary care about that.
We have another question for you from Jeremy. What specifically is a nurse practitioner? I know there's lots of nurse types. What makes a nurse practitioner different? Also for Per, Jeremy writes, I got a kick out of your "it had to be done" photo on your wall where it's slicing the pear open. Oh, that's clever. I didn't catch that.
Yeah, so an artist, they go by Retro Whale on Etsy. I've had a lot of their work over the years, and so a few years ago I had seen that available and I didn't have the money to buy it at the time, and then when I got the news, like, hey, you're gonna have open heart surgery, I reached out and was like, I think I need to make this happen now. So that hangs in my bedroom because it had to be done.
You are the pear.
So, correct.
Being sliced open. That's incredible. Oh my gosh, I love that. Let's see. Another person saying
that nurse practitioner, what the difference
that's right. We got sidetracked.
I got so excited about the peer.
Okay, tell us about nurse practitioner, how you became one, and what makes it different from being an RN.
Sure. So RN is a 4-year degree, and a nurse practitioner is a master's or a doctor of nurse practitioner that does some additional training. And so we can see patients, make diagnosis, order tests, order labs. We work with great collaborating physicians, so I always say we're not an island. We have the best resources here, especially at KU. So just a little bit more training and get to do a lot more of what I love to do.
That's amazing, and we're so glad that you're all here. As we wrap up this conversation, Per, I want to start with you, and I do want to ask you about your dad who passed, and you had talked about how you tried to channel him as you were going through this?
Yeah, so he was the eternal optimist. He passed away, we're coming up on 2 years now from multiple myeloma. Miss him a lot, and, you know, obviously wish he could have been here to see me on the other side of this. But that eternal optimism, something he used to say was like, well, we're getting there. And so I was thinking about that this morning, where it's like, well, I continue to be a work in progress, but I'm getting there. And so that's sort of thinking about his mindset of things and trying to keep that going forward. So
you feel like he's here with you?
Yeah, I mean, you know, there's reminders of him around my house, and you know, always, what is it? He was big into genealogy, and I guess when you think about, you know, your ancestors and your genes, technically he's part of me. So,
He is.
You know,
He is part of you.
Yeah.
It's beautiful.
Yeah, thanks.
Mary, what would you like our viewers to take away from this conversation?
Yeah, I think if nothing else, please get your annual physical, do your preventative care. If we catch things early, they're easily managed, and just make the time to invest in yourself.
Dr. Crawford, thank you for introducing us to Per. You told me you had an incredible patient, and you were right. He's so interesting. What do you want our viewers to know about Per's journey, and also what they need to know moving forward?
Yeah, I mean, obviously we have a special bond just because of our similar experiences. I think, you know, the first thing I would say is the Ross procedure is not standard of care for aortic valve disease. Maybe it will be in the future, but it still is under intense scrutiny because it's a higher risk operation than a normal aortic valve replacement. And you have a lifetime of surveillance for the 2 valves that have been fixed. What I would say is it has been incredibly helpful to have buy-in here from my partners, especially Dr. Dayon. The way we set this Ross program up is that we do all those operations together. So 2 attendings, we work well together. I think we both have experience with the operation, and it makes for better patient outcomes. And so it's not only his input and his collaboration, but also the buy-in from the cardiologists that say, yes, we're comfortable with you pursuing that operation. And for Per, it was absolutely the right operation.
How many do you do? Just how common is it for you to do a Ross procedure?
So we had not done any in, I don't know, maybe 5 to 10 years until last year. And so now we're doing 1 or 2 every month. You know,
That's fantastic.
There's a steady influx.
Well, thank you, and we do have an amazing cardiology team, an amazing team here overall at the health system. Thanks for taking time to join us, Dr. Crawford and Mary, and Per, thanks for sharing your journey.
Thanks for having me.
And a little bit of your life with us, and
Well,
you're going to have fun
thank you.
sleeping in those socks, too.
Yeah, absolutely.
I might ask to have a pair commissioned for your mom. Thank you so much for joining the conversation today. Coming up tomorrow, a remarkable survival story. He was only 29 when a plane crash left him with devastating injuries. We will walk through his recovery and the complex surgeries, giving him a second chance at life. That's tomorrow at 8 a.m.